Hello, Dr. Kelly.
Hi there.
Hi.
How-
So I'm good. I hope you are too. We're all trying to stay as good as we can these days. Can you tell us? By the way, welcome and thank you for speaking to our audience, our community. It's national and large, and a lot of people are eager to hear your thoughts on the advantages of PSMA, PET scans, and how to combine therapeutics and diagnostics to kill prostate cancer and keep us alive. Can you just share what kind of doctor you are and where you practice and what you do?
Sure. Again, thank you so much for giving me the opportunity to share my experience in PET-CT imaging, in PSMA PET-CT, and in Theranostics in more general. I'm a nuclear medicine physician. I was trained in France. I worked in France before, as you can hear. And now I work at UCLA for 5 years. I'm finishing my fifth years. And here I do a lot of clinical research. Currently, most of the clinical research ongoing in the nuclear medicine field, all the radioactive drugs, radiopharmaceuticals, is a lot about PSMA, which is a target in prostate cancer. So that concerns a lot of prostate cancer patients, but there are also other many applications in cancer and non-cancer patients. So I currently lead the Theranostics program here at UCLA. And very happy to share my experience with PSMA PET and answer any questions that might be of interest.
That's super, and we're very grateful for your self-introduction. But you also mentioned Theranostics, which I'm sure is making a lot of our audience heads spin around. Let me introduce Alan Edel, who's a strong member of our Malecare community, and he'll ask you what Theranostics is, and the two of you can have a nice chat for the next 20 or 30 minutes.
Well, before I do, I want to congratulate you and Thomas Hope at UCSF in getting the first FDA approval for your gallium-68 PSMA PET scans. I know the amount of clinical trials you've done that have gone into getting that approval, and it's daunting. So it's a well-deserved pat on the back for you guys. And I understand that Medicare has now approved it. Is that true?
It is true, yeah.
So patients no longer have to shell out $3,000 to get your PET scan, correct?
Medicare patients, that's true.
Yeah. And I'm sure many private insurance will follow soon after if they haven't already. So that is indeed wonderful news. To get to what Daryl was mentioning, there are three terms that are thrown around a lot. One is molecular imaging. The other is molecular therapy, and the third is theranostics. Can you tell us what they mean?
They are all linked, first of all. I will start by Theranostics. Theranostics, you can hear and see in the words, there is thera, which comes from therapeutic, and you have gnostics, which comes from diagnostics. So it's the combined approach of an imaging and or diagnostic and therapeutic approach or tool aiming for the same molecular target. And this goes with the paradigm that you see the target and then you treat the target. Or if you don't have the target, you don't treat. Or individualized medicine. You don't treat all the patients the same. You first see if the target is expressed before you treat. That's what it means, basically. It can be done with radioactive molecules, but also with other approach, not using other things than radioactive molecules. You can do it with...
Like
it's a targeted approach, that's the thing.
Yeah.
There is this concept of molecular target. Now it's a transition to go to molecular imaging and molecular therapy. These terms are very, let's say, very broad. There is no, there might be some accurate definition given by this or this expert society, but at the end, these are kind of basket terms in which we put many things. To stay, let's say, in line with most of the accepted definitions, I would say that these are mostly targeted approach, again, that use a molecular target. So when we say molecular imaging, you can do it with radioactive agent, but there are also other agents, other physical products that you can measure and make images out of, but they are all aiming for molecular target, a molecule. So that's why we call them molecular imaging. They're different than, for example, CT, X-ray, or just standard MRI, where you just take an image of the body and you see how it is. Here, you're really you're trying to make an image of the molecule repartition in a body, so the target expression. And that's the same for the therapy. When we say molecular therapy, it's not a very accurate term. At the end, I think it would mean really that you treat these lesions using a molecular target or a molecule. So it goes again with the theranostic, and it's really related to a targeted approach, unlike, for example, chemotherapy in cancer that is non-targeted.
Focusing on PSMA Theranostics for a moment, what is the current status of that? What are you currently seeing and treating?
So PSMA, just to be sure that everyone is on the same page, PSMA means prostate-specific membrane antigen. So it is a protein that is highly overexpressed by the prostate cancer cells. And so it is a very relevant molecular target for any prostate cancer imaging or therapeutic applications. It is only expressed at low or, let's say, intermediate level in non-prostate cancer tissues. So you have a good ratio between high expression in cancer cells and low expression in background organs or normal organs. So that's why it's a good target. And you have such targets even more specific in other cancer types, other applications. And so this protein has been used with radiopharmaceutical to do either imaging or therapy in the past, let's say, 10 years. The whole PSMA radiopharmaceutical, let's say, experience come from Germany initially, and then in Australia, and then came a little bit all around the world, and in the US in the past 5 years. And you can use this target to do targeted PET imaging or to do targeted radionuclide therapy. So you inject a molecule that goes specifically to the PSMA target that is internalized into the cells, the prostate cancer cells. On this molecule, you have attached a radioactive agent, such as gallium-68 or fluorine-18. These ones are radionuclide that emits positron. And with this, you can detect it out of the body and make images out of that using a PET-CT scanner. And so you make an image of where this PSMA target is expressed. And so with that, you can do many applications. You can detect more sensitively where the lesions are than before, even when they're very small. Or you can assess the expression of the target if you want to do a therapy targeting this molecular target. And so now are being developed many therapy radiopharmaceutical compounds targeting the PSMA, lutetium PSMA, so lutetium-177, that's a beta-emitting agent. And you have many other types of radionuclides that this time emit radiation that don't really go out of the body, that are emitted and stay maybe a couple of millimeters where it has been emitted, so very selectively, locally, and deliver high energy and induce cell killing where it has been emitted. So very different types of radiation than the one you use to do imaging.
Okay. One of the most exciting developments to me is that the FDA approved PSMA imaging for high risk or unfavorable risk prostate cancer. Are you using that on a lot of patients now?
Yeah, every patient. So at UCLA, most of the patients, until recently, there was still some financial issues. Patient has to put on the table upfront $3,000 to cover the cost of the scan. Here at UCLA, I talk about only UCLA. So this could be a limiting factor. But other than that, we do up to 6 or 8 scans a day just for prostate cancer every day. And so there's a lot of demand, a high need coming from all around across the California, Southern California, but all across the state. And yes, many patients are at initial diagnostic with unfavorable intermediate risk or high risk prostate cancer. Also, we have a lot of recurrent patients, that's for sure. But yes, we do a lot of scans for these indications.
That's just wonderful. It's such a big change in the way that unfavorable risk patients have been treated in the past when we didn't know if there were distant metastases. And now we do, at least down to 5 millimeters, which I guess is the size limit you can see on that. I wanted to get into your FAPI research, which to me is the closest we've ever seen to a pan-cancer kind of detection. Can you tell us what FAPI is and where you are with that?
Sure. So here we're switching a little bit of topic because we kind of move out of the prostate cancer type and we go to other cancer types. First, I have to say that as a pan-cancer imaging agent, FDG was and is the standard of care and works very well in many cancers. FDG has completely changed the imaging landscape 20 or 30 years ago. For cancer imaging, you can assess much earlier than with CT, just the change you would see on a picture. Here you can see the functional change, the activity of the cell. So you can detect with more sensitivity the active cell, even if they are small, or you can detect the effect of a therapy earlier than before it shrinked or it grow just by looking at the activity. So I just want to make sure that as a pan-cancer imaging agent, we have FDG that is already the best.
I'm sure the potential is for a pan-cancer therapy agent if FAPI is used with lutetium or some other radioactive element.
Yes, many people want to reproduce the success that has been observed with somatostatin receptor targeted and PSMA targeted radiopharmaceutical approach. So we have lutetium PSMA, we have lutetium dotatate. This is in another tumor type, neuroendocrine tumor types. That was kind of the same approach that we have here with PSMA, the PSMA PET agent and the PSMA therapy in neuroendocrine tumors. And these were success stories. And so now people want to apply this concept to other cancer types, other targets, such as FAP. People are trying that because it's very attractive. The group in Heidelberg showed images of FAP-targeted PET scans in patients with cancer, multimetastatic cancer, 2 or 3 years ago, and the images were really, really impressive. You see clearly black on white with very impressive contrast and very, very easily you see the lesions because there is basically no background. And based on that, there was a huge hype and a huge wave of interest from the academic and also industry research environment to use FAP because based on these images, it was easy to assume that the therapeutic index would be excellent as well, meaning a very low therapeutic effect in background organ and a high therapeutic effect in the tumor lesions. That's what the images were suggesting, and that's why there is all this hype around it. Let's make sure we're all on the same page of what is it. So FAPI stands for fibroblast activated protein inhibitors. So the fibroblasts are the cells that are in the connective tissues. You know, they are not. They can be differentiated into different subtypes depending on their function, but they are mostly like the cells that are in the connective tissue that make all the other cells tending together. They are activated fibroblasts when there are some wound process. So if you have a scar, if you have lesions, you have some inflammation, the body will try to repair and the fibroblasts will be activated. So any fibrotic process, any scar process will have some activated fibroblasts. And then in cancer, the cancer induces a reaction around the lesions itself in the microenvironment around the tumor with activated fibroblasts. We call them cancer-associated fibroblasts because they are around the cancer. And they become activated. They have specific properties to interact with the cancer cells. And it seems it's a bit like the cancer cells turn these cells, the fibroblasts activated, to their service to feed them, to enable them to grow more into the organ and the tissue. So there are very specific and tight interaction between the cancer cells, which are cancer cells, and the cancer-associated fibroblasts, which are not cancer cells, that belong to the host, but that serve the cancer progression. These cancer-associated fibroblasts, they express a lot this protein, FAP, fibroblast activated protein. And now we have, again, radiopharmaceutical agents that can go to this protein, FAP, very selectively, very specifically, at very high intensity. And you can then make images of these cancer-associated fibroblasts that will show basically all the stroma reaction, the surrounding reaction around the tumor lesions. And that's what you see on the images, very, very bright like that. So based on everything I just said, first, you know, it is not cancer specific, it is fibroblast specific. So of course the fibroblasts are around the cancer, but you can see that in other process, non-cancer process. And that raises the question of if you target these cancer-associated fibroblasts, will it effectively treat the cancer cells themselves or not? And that's the whole question. So I put that on the table because we're still much earlier in the development stage than with the PSMA or somatostatin receptor targeted approach. We are very, very, very early in the development, and we still don't know very well if this would work the same way or not. People are trying. There are some early preliminary experiments that are starting to be reported worldwide. And so far, we have not seen yet these very impressive images we have seen, for example, with PSMA in a patient full of disease. You give 2 cycles of PSMA targeted treatments, and then on the next scan, there is nothing anymore. We have not seen that yet with FAPI targeted therapy approach.
Disappointing, of course, but is it possible to combine them to go after the tumor stroma with FAPI and to go after the cancer cells with PSMA?
That would be an approach with PSMA, but more globally. I fully agree, and I fully support the idea of the combination therapy approach. You have an agent that can kind of clear the path and enable some maybe immunologic reaction in the stroma. So you will have if you treat that, you can decrease the physical barrier that represents this fibroblast. You can induce many crosstalk pathway immunologic reaction based on that. That can enhance both this phenomenon, that can enhance the effect of another treatment, which would target directly the cancer cells directly this time. So yes, I think that in combination, it can work very well. It just has to be shown which would be the most suitable combination with which target, which cancer type, which all this needs to be explored and assessed. But yes, I think in theory it can work.
Great. And you have a clinical trial running now. Is that currently recruiting well?
Yes, we have a couple of exploratory studies that are being conducted at UCLA. These are purely academic. And we are a little bit limited in our capacity of the size of the trials that we could do because of that. So these are exploratory studies. We're still at the early phase. We are looking for patients who will go to surgery for their cancer, because for us, it's a way to use the tissue that has been removed during the surgery as a gold standard, and then we can correlate that to the FAPI PET imaging findings. So we have about 50 patients like that that have multiple tumor types, and we're still at the early phase. So far, I can tell you what we see on the scan. When there is high FAPI uptake, it means there is high FAP expression that we see on the tumor piece afterwards. So that's at least validate further the FAPI PET scan. Now, in terms of prostate cancer, we have some trials that also allow the recruitment of FAPI prostate cancer patients. And it seems that prostate cancer is not a cancer that induces a lot of stromal reaction, at least at the early stage, what we call desmoplastic reaction, stromal reaction, all these kind of surrounding cells, inflammatory process that occurs around the lesion doesn't seem to be the most prominent in prostate cancer when compared to other types of cancer. It may be different at very aggressive or advanced stages when the disease evolves to more aggressive phenotype. Maybe there is more inflammation, it's be different. But at early stage, it's clearly not like PSMA where you have this increased detection for small lesions. This will not happen with FAPI here. It will not happen. There is not enough of this fibroblastic reaction around.
Yeah, that's disappointing. But what about other molecules? I know I've read about bombacin, RM2, CD46, HK, and several others. Are you looking at any of those? Is there hope there?
So you're right. It's all about the target. A good molecular target is, in a sense, a target that is expressed at high level in your mechanism of interest, such as here prostate cancer, and at low level in everything else. That is a target of high interest. And so the identification of such targets of such protein is of course a high interest in the scientific community. There are thousands of it, and people are screening peptides expression and everything. Like there is a lot of work going on in that sense, and multiple molecules that can then bind specifically with high affinity to these targets. Again, there are thousands and thousands of candidates. So there are a lot of things are going on there. I'm sure in the future we'll have even better targets with higher tumor to background ratio, higher specificity, with molecules that can go even more specifically to that target. I'm sure that we'll have that. As of now, if you talk about what we're doing here at UCLA, we limit ourselves to PSMA and FAP. It's already a lot of work. We cannot do them all. And I do mostly the clinical research side. So that's when it's already kind of pretty well advanced and downstream that we're already in the patients. Because many of the targets, they are being tested in vitro or in preclinical studies. Upfront, this I do a little bit less. I can talk about bombacin, for example. They do a lot of that in Stanford with Dr. Yagaru. And I think it can be a relevant target in some lesions or in some cancer or in some patients, because at the end, cancer is not one entity. Cancer has some heterogeneity with different and various phenotype, different expression of protein. And in the best of the world, you would have for each patient different targeted molecular imaging and therapy adapted to the phenotype of this specific cancer. We're not there yet, but ultimately that would be the aim. So you would have some patients that are positive by PSMA and they will respond very well to PSMA targeted therapy, but some others, bombazine would work maybe better. And then here you would target them with another target, which is RM2 and bombazine. And you can expand this concept to many other targets.
Or perhaps combine them in the same patient. That's very exciting. The tailoring of imaging and therapy to specific patients. Going back for a second to the older standby PET indicators, sodium fluoride and FDG scan, are you seeing use for them in prostate cancer patients?
These agents are available for a very long time now, like 30 years. You have FDG and NAF. And there was a time where we maybe know less how to use them in prostate cancer. And so we define them as probably not very useful, especially FDG. NIF, the fluoride was still useful up until recently in the bone scan. But now that PSMA came and there was much more research done with PET-CT imaging, and sometimes you have some cohort of patients who had dual FDG and PSMA, there is kind of a new, it's like if we're looking back at FDG, it might be useful in some patients. And yes, it's completely useful in some patients. FDG, for me, is the best for cancer-targeted approach, cancer imaging or cancer therapy. FDG remains the best. What the cancer cells do, they consume a lot of energy, a lot of glucose, because they are moving fast. And the more they do, the more aggressive they are, it means. So FDG can show aggressive cancer, prostate cancer. And many of the prostate cancer, it's not like pancreas cancer or others. At the beginning, they're pretty indolent, and many are, you don't even know if you really need to treat them or not, because they are not very aggressive. And so in them, for sure, FDG is useless and should not be used. And before, there was the urinary excretion. So I think FDG was considered as non-useful because it was maybe not studied correctly. Now that we have more refined data, and we can clearly see in advanced patients, for example, the lesions that are aggressive, some have become PSMA negative. The lesions that are both FDG positive and PSMA positive. And so we clearly see this kind of heterogeneity of the disease, different behavior and phenotypes that are reflected by these different molecular agents that we use for imaging. So I really think there is a huge interest for FDG and also for NIF. Also, although if I have to choose one, I choose PSMA for prostate cancer. If I have to choose two, I choose PSMA and FDG. And if I have to choose three, I would choose also the bone metabolism reaction. Bone scan and fluoride, they show the bone reaction around the metastasis that occurs in a reaction to the metastatic invasion. So, of course, prostate cancer is a cancer that goes a lot in the bone. So there is a lot of bone metastasis. So that's why these agents are still useful. And sometimes you can have, again, some heterogeneity, lesions that are being positive by fluoride, negative by PSMA, or vice versa. But I feel that bone imaging is not cancer-targeted imaging. It's the surrounding bone reaction, whereas PSMA is directly expressed by the cancer cell, and the FDG is directly consumed and taken up by the cancer cells. So I do have a preference for direct cancer cells imaging. And in the best of the world, in Australia, that's what they do. They do every patient that is referred for metastatic castrate-resistant prostate cancer patient considered for PSMA-targeted therapy. They do dual phenotyping with both PSMA and FDG PET for everyone, and they take the decision based on that. I had a couple of stories where I had access to such images in the US patients because some patients happen to have these two scans And it works very well, and it gives you much more confidence for an individualized approach where you see a good match or mismatch.
Yeah, in fact, you did it for a friend of mine, and in his case, he had so much PSMA avid lesions and PSMA non-avid lesions that were FDG that showed up on an FDG scan that we determined that it was useless for him to have lutetium therapy at that point. And that was wonderful to be able to rule that out. So later this year, I think the FDA will approve lutetium PSMA therapy. The way the Vision trial was run, they didn't do FDG scans, only PSMA scans. Would you recommend to patients that they do both?
Let's go step by step. I think first, you're right. It will be approved probably in 2022. And that's a huge milestone, and that's really great. And we should go step by step. It doesn't mean we should do everything at the same time, do individualized dosimetry, more phenotypic imaging, FDG. Treatment is approved and is efficient in most of the patients. That's good. Then we need a little bit of screening for that. So doing the PSMA PET screening like was done in Vision to make sure there is not too many PSMA negative lesions. These are really the one that carries the bad prognostic. I think that's good. And I think that would be part of the label. That's my expectation and prognostic. Then if you want to do better, maybe yes, there is some room for improvement with, changes the dose, changing the activity we do, doing some image tailored, individualized activity dosimetry with other imaging agents for patient selection, such as FDG. I think it can work very well, but it should not be a requirement. That's my point. You don't need an FDG to do PSMA therapy because it has been shown that PSMA therapy is already, when you take big cohorts, pretty efficient, and you should just try and see. Now, on the individualized approach, if you have your patient in front of you, yes, it can be useful, but it's different than putting it in the guidelines with a requirement or having an individualized patient that has access to different technology. These are different things. But in the best of the world, you would have easy access, coverage, no delay in appointments, no money to put on the table to all this technology, and you just do the best. In that case, FDG, I would strongly recommend. Because that's not the case, and you don't want to delay the process, you don't want to create additional financial burden or anything, things like that can just delay the treatment. No, I would not recommend that for guidelines in the US, at least, because you don't need it to try.
Great. Thank you so much. This has been very enlightening. And you're certainly on the leading edge of theranostic therapy, and you've turned UCLA into a U.S. center for theranostic imaging and therapy. So thank you for doing that. I know many patients are grateful for that. Daryl, did you have any other?
So if, let's talk about a bit on what the patient, just like 5 or 10 minutes, what the patient experiences when you're treating them. So does PSMA targeted therapy hurt?
So in comparison to chemotherapy, it is much better tolerated. Again, it's a targeted approach, unlike chemotherapy. I compare it to chemotherapy because it will be approved in metastatic patients who are in the chemotherapy treatment algorithm. That's kind of their other options. They will have access to other type of systemic therapy, immunotherapy, or others. But that's to what treatment we should compare PSMA targeted therapy. And in that case, it is much better tolerated because it's targeted. Now, it is still something you inject IV, and that goes systemically in the whole body. and that deliver radiation therapy. So there are some side effects, of course, and it means that we're doing something. So which are the main side effects? It goes into the salivary gland because the PSMA ligands, they go to the salivary gland and deliver locally some radiation therapy there. So very frequently, up to 70% of the patient, they have some dry mouth effect. But with lutetium, I never heard a patient who told me, oh, it's too bad, I want to stop the treatment. I cannot tolerate that. So it's considered as mild or moderate, or at least not severe. So, but that's very frequent, up to 70% of the patient. Then you can see on the scan, usually these two black kidney, very intense because the kidney express the PSMA target, and they also excrete the tracer or the treatment that is not being used from the blood into the urine. And so you have a lot of activity in the kidney. So initially, when people were doing that, especially the FDA, they had some concern about the kidney toxicity. So we monitor closely the kidney function before and during and after the treatment. But up to now, I've seen very, very little kidney toxicity. It is actually very well correlated on the kidney toxicity side, at least on a short-term follow-up, because sometimes, the kidney toxicity can happen years or years after, but this we don't have yet mature outcome data to look at. But on a short-term basis, let's say on acute or subacute, it is very well correlated, unless patients have a prior kidney disease or obstruction. Other than that, we don't see a lot of kidney toxicity. I think you would need to inject much higher dose of radiation to see some kidney toxicity. Then the other main side effect will be the bone marrow toxicity. So the bone marrow is the organ that produces white blood cells, red blood cells, and platelets. So you monitor it with blood counts at regular intervals. And here you can see some hits, of course, a little bit like with chemotherapy or with many other therapies. You see it even more when the patient have a lot of bone metastasis, because it means a lot of treatment will go to the bone, which is good. It will deliver radiation to the cancer metastasis, that's good. But it will also irradiate a little bit the surrounding healthy bone marrow cells, and it will hit a little bit the bone marrow function. So we usually monitor that closely. We don't want to impact and damage too much the bone marrow function. So we usually wait that it recovers to normal before we administer the next cycle, if ever there is a little bit of drop. Sometimes in very advanced patients, we do require like transfusions and things like that that we do with the medical oncologist.
So patients are familiar with brachytherapy and the idea that after having seed implants, you're going to sort of keep a distance from relatives and children and don't bounce babies on your lap. Is there any restrictions around that for PSMA-targeted therapies?
Sure, it's a radioactive treatment, so there is some radioactivity. So patients, once they get injected, it circulates to the body and radiation is emitted. That's what we want. Most of the radiation of the lutetium molecule is emitted only a couple of millimeters where it has been emitted. So it goes to the tumor lesions, it stays there, and it delivers locally a radiation therapy. We can call that molecular targeted radiation therapy. So that's good. And this will not create some radiation hazard or radiation safety issue for the surrounding people because it's only a few millimeters. However, there is a little bit of gamma. So it's another type of radiation, let's say maybe 10% of it, that deliver not high dose radiation, so very low dose, but they travel out of the body. So usually that's the one you can use to be detected and make images out of it. So this one, they go out of the body. So there is a bit of gamma radiation. You can compare that a little bit to X-ray radiation that come out of the body of the patient. It is not a lot, completely way below the thresholds that would require to do anything like hospitalization or thing. So it doesn't require any rules. Now, the common sense rule with radiation, I usually say that, how does it work? It's like a heat source. The closer you are, the more radiation you get. The longer you stay close, the more radiation you get. So just basic rules of radio protection especially for gamma ray that are being attenuated in the air, is you take 1 or 2 meters of distance, you will get almost nothing from that. And if you do a hug, you will take a little bit. But if you do a hug for 10 minutes or 5 minutes, that's okay. You will take even 10% of an X-ray. If you stay together close for 24 hours, very close by, then yes, you can take a little bit, but you wouldn't take nothing in the range on the amount of radiation that would actually harm somebody around you that would be required hospitalization. It would be like maybe you do an X-ray for nothing, even if you spend 24 hours like that. Of course, we don't want people to have X-ray for nothing if there is no medical indication. But usually I say that during the first 1, 2, 3 days after the administration, I say, just keep your distance and be mindful with common sense rules. But there is actually no real risk that has been shown or proven with that.
Do you find your patient? Sorry, go on.
The last thing with the radiation safety is most of the non-use parts initially is excreted through the urine. So during the first 12, 48 hours, the urine would be radioactive. So we usually really recommend to be very clean, flush 2-3 times the toilets, being clean and being mindful about that. Once we understand a little bit how radiation works and the amount of radiation we're talking here, so of course, we're not talking about anything related to radiation therapy, such as brachytherapy seed. It's like, it would be the 2 millimeters there for the patient. The one that goes to the surrounding patients, but these are very little. So once we understand that, and that we understand that the urine will be radioactive during the first 2 days, and that if you don't stay close a long time, you will get probably nothing, then it's you can apply common sense rules.
Sure. And just 3 or 4 more minutes before we wrap this up. But do you find that patients will sort of not sleep with their partners, wives or husbands after treatment, regardless of what you say?
So if you would use another radioactive radionuclide, such as iodine, we would probably recommend that. With lutetium, it is not recommended. I don't think it's crazy to do it. It will be for 1 night or 2, again, when most of the radiation is still circulating. Then it will be excreted after 2 days and only will remain the radiopharmaceutical bind to the target that emit locally the radiation, then you're safe. Maybe in the first night, if you want to sleep in a separate bed, it's okay. It's absolutely not a requirement per the US rules and threshold. But why not a common sense rule if you're really mindful?
Right. So lutetium isn't going to start breaking up marriages and partnerships necessarily.
Yeah.
Okay, so good for that. But might another concern that patients have is around secondary tumor formation. Might the lutetium or any of the PSMA targeted nucleotides cause or incite another cancer, perhaps a bladder cancer?
So bladder cancer, I would be surprised. So the secondary tumor induced by treatments, usually you observe these with chemotherapy and radiation therapy. It's true. And you have to wait usually a time interval of 3 to 5 years minimum to observe this. That can happen. And this happens mostly, of course, in young patients because you have more time to see the occurrence of such a second event later. And also because younger patients are more sensitive to radiation. The effect of the radiation is more active on younger cells. Now that I put that on the table, in prostate cancer patients who are metastatic, so far we have not observed that a lot. It's a bit like the kidney toxicity I was talking about. Because this is not young patients, most of the prostate cancer patients, they are not like lymphoma or breast cancer patient of 20 years old. They are very at a much more advanced age, so you have less time to observe second cancer like that. And it's hard to say if this patient who receive also radiation therapy and who receive also chemotherapy would have an increased risk only from lutetium PSMA. It would be hard because this patient would be heavily treated and it will be hard to define which one caused what.
And the newly diagnosed patients in our audience, and there's usually like 4,000 to 6,000 people watching these videos and such, and maybe a quarter to a third at least are have just gotten their Gleason scores or started their discussions. They're asking and banging on my back virtually, why can't I have this? I mean, a targeted therapy, that has minimal consequence to perhaps urinary and erectile function. Why do I have to wait till I'm both castration resistant, and have metastases that show up on a scan? Why don't you give this to me now?
So you're right. It's a fair point. So in the let's say general paradigm of cancer treatment, the earlier you treat, usually the higher chance you have to get better success rates and success numbers with your treatment, because the disease is less aggressive, because the disease has less mutated, has less spread out, and so you have higher chance of treatment. So I think earlier and earlier we'll move the treatment at earlier stage, and trials are being done in that sense. And the first approval will be for a patient who already failed 1 or 2 lines of chemotherapy, so very advanced, very down the line. But I think in the next coming years, we'll move earlier, before chemotherapy, and maybe even earlier. Now, having said that, my personal feeling is that radionuclide therapy remains a systemic agent, something we inject through an IV line, to do something that local treatment cannot do. And my view is that when you have a localized tumor that is only localized, and you know that from the scan, for example, you have better chance to treat it entirely with surgery or external beam radiation therapy. Surgery will remove it physically, and external beam radiation therapy, you can give very high dose to this local area. Whereas with molecular radionuclide therapy, you can reach multiple sites in a targeted manner, but you still deliver less radiation dose to these targets. So you have a little bit of less treatment effect. So when you know that the disease is confined to one spot, I would not choose systemic molecular radionuclide therapy. I would choose surgery or external beam radiation therapy to blast that only one spot, just to give more chance to the treatment effect. So I think it's more really a treatment that is adapted for metastatic disease. Now, people will try, and I'm sure it may succeed as well, to use it as a neoadjuvant or adjuvant treatment. You would add this on top of surgery or external beam radiation therapy to treat all the non-sites or all the non-big sites that you cannot see or remove with surgery or radiation therapy. You will treat them with this targeted agent. So this can work, again, in combination as an adjuvant or neoadjuvant treatment to focal therapy.
And finally, you've got patients coming into your office. You see patients 2 or 3 times a week, I imagine, something like that. What do they, after you describe what you're putting on offer for them, what PSMA refers to, what lutetium, what your work actually is and how it could help them, what are like the top 2 or 3 questions, or top 1 or 2 questions that a middle-aged to older man sitting in front of you is going to ask or has asked you, and how have you responded to it?
They usually ask me, okay, when is the appointment? I want to do it at the time. So far when they come to UCLA and to me, I'm really like on a very down the line. So they know what they want. They're very eager to receive either the scan or the treatment. So they really want to get it done. And then if there are some questions or concern, it will be the radiation safety, like you just brought up. It will be the treatment efficacy, like what do you expect in my case to see? Or how do you monitor the effect of the treatment? These are the questions. So we use PSA, we use the clinical symptoms. These are for the treatments. For the scans, the questions that comes often is when should I do the scan? Or when should I repeat the scan when the scan was initially negative? So that's a question that I receive frequently.
Actually, your patients have brought up actually what should be the last question, or one of the, like, how do you know when this is working and how do you know when it's not, and stop it and say.
The early phase of development for all the therapy response assessment. Most of the therapy assessment so far has been done with, let's say, conventional methods using PSA, CT, bone scan, and the symptoms. But there may be a way to see the response earlier with PSMA PET imaging, for example. It's just that the criteria to say response or not are not exactly yet completely set up. But I think that's where we are going. So in the future, I think we will use molecular imaging agent to assess response to therapy. But for now, it's still PSMA, CT, and bone scan, the classical one.
Dr. Kelly, thanks for spending time with us. Thanks for an extremely interesting high-level conversation. Alan, thank you for working with Dr. Kelly and, during this conversation and bringing out important points for all of us to try to understand. One of the nice things about video is that if you didn't understand it the first round, you could always click repeat and watch it again and again till you get it. Sort of like shampooing your hair till it gets clean. Sometimes you need to do that multiple times. But Dr. Kelly, thank you for your research. Thank you for the care that you give your patients. And thank you for being part of Malecare today.
It was really a pleasure and happy to come back again.
Great. Okay. Au revoir.
Thank you.